Thank you very much, Mr. Chairman. Good afternoon, ladies and gentlemen. It's really an honor to be part of this incredible and excellent meeting. And I'm very appreciative to the organizers that I can be part of it. I am aware that arterial hypertension is less a sexy subject than chronic heart failure. But anyway, it's important for anesthesiologists because of its prevalence. We know that a large proportion of patients present in our community with hypertension. What I'm going to address here is risk assessment, pathophysiology, a few thoughts about intraoperative management, and I immediately add that there is little new evidence, but there is insight. Evidence-based medicine doesn't bring us very far with regard to intraoperative management, but there is increasing insight in the pathophysiology, and there are new monitors that may help us to better manage these patients. A few words about outcome, and then some opinion-based recommendations. And you can find these back in the paper I referred to, something we wrote recently in Current Opinion. Now, to pimp it up a little bit, as it is less sexy, I have one question for you. Because I thought I had to include the question with the smart system, which is very smart. This is a 76-year-old male presenting to you on the pre-op with surgery ahead, a robot-assisted prostatectomy, or urologists love robots. They think it's much better. We think it's much more expensive. In the history, the patient says, well, I see a general appearance that is good. He says that there is no cardiovascular events, but he has arterial hypertension. Can do normal efforts, can do flight of stairs, let's say, and mild lung problems, doesn't take medication continuously, but he has been smoking. So the typical patient for urology, and he takes diuretics and a beta blocker, Soprol 5 milligrams. On physical exam, you see normal heart rate, sinus rhythm, but the blood pressure is high. You measure 175 systolic, 105 diastolic. Now, what are you going to do? Because this patient needs an operation tomorrow. Now, I don't know how to handle this, but I think you have to vote. And there are up to four possible solutions. Either you proceed to surgery because, you know, your surgeon is not very happy if you postpone something. So you continue with the beta blocker, that's what we know. Or you take the decision to postpone surgery and send the patient to the cardiologist first. Third option, you increase the dose of beta blockers because obviously it's not sufficient, and you proceed to surgery. Or four, you postpone surgery, you add the triple therapy, the third option, that's an ACE inhibitor to control blood pressure, and you reschedule the patient in 2 weeks to see him back. Now I think it's time that you have to bring out your vote. And I'm not sure how I can control who is voting. But I receive a sign that I should wait. Can I? Okay. Everybody says we proceed to surgery and continue the beta blocker. How many votes? Everybody voted? No. Says no. Can I continue? I cannot. Anyway, I think I'm going to continue because I just have 20 minutes. You had the right, or at least the persons that voted had the right solution. You're well trained, you're well aware. Indeed, because the guidelines, and I still use these as the current guidelines, although there are new guidelines, you refer to the Cardiovascular Society of Canada, that are quite different, but need to be validated, to my opinion. We adhere to these guidelines, European, both the cardiologist and the anesthesiologist have written them, and they say only grade 3 hypertension is a reason to cancel surgery. Grade 2 is acceptable, and this, what I described here, was grade 2. So yes, you were right. We don't have to call in the cardiologist all the time. It's not going to make a difference. That's what the evidence says so far. What is important, though, I need my glasses, is that if there is a new diagnosis of hypertension, that's something different. That's not under control. If there is reasons to indicate things that indicate end organ damage, like cerebrovascular accident, that's a reason to go further. And also, the general cardiovascular risk is more important than the blood pressure alone, which can be white coat hypertension, something that you also know about. So this is how we define hypertension. Grade 2, that's what our patient had. Grade 3 is above 180, above 110 diastolic. And there's also something like isolated systolic hypertension, where the diastolic pressures are normal. This is something we can go into later on. The prevalence is high, as I told you. It increases with age. And so grade 3 is called an emergency. And what's in the name? An urgency means that there is an emergency above 180 plus organ damage. So to summarize, for risk assessment, only grade 3 is a reason to go further and investigate, cancel. New onset hypertension is one. We take into account the total cardiovascular risk, for example, Lee index, as it was suggested earlier. Look for signs of target organ damage, like renal failure, creatinine. And if you suspect that it is secondary hypertension, such as in a pheochromocytoma. These are reasons to investigate. Now, pathophysiology, second subject. It's my favorite subject. And most is in the textbooks, but there are some new things that perhaps I take some time to go through with you. We know that there is arteriolar thickening. The size of the wall, as a ratio to the lumen, increases in an arteriole. So that's why systemic vascular resistance goes up, heart has to work harder, tension goes up. In addition, there's evidence now that following apoptosis, there is less capillaries, so capillary rarefaction. And importantly, larger arteries are stiffening. They lose their compliance. The heart suffers usually because it has to work harder from left ventricular hypertrophy, visible on ECG, on echocardiography. And that means, or is almost synonymous for diastolic dysfunction. And in addition, there's capillary rarefaction, and there is reduced, for that reason, reduced coronary perfusion reserve. So the heart is at ischemic risk and diastolically dysfunctioning. And there's also new hypothesis that there are neurohormonal changes that link diabetes type 2 to the development of hypertension. But these, to my opinion, still need further investigation. What does stiffening of conduit arteries, and conduit arteries means the bigger arteries, the aorta, the larger arteries. What does that mean, and what is the implication? Well, sometimes or most often there is referred to the Windkessel phenomenon. That is actually something that firemen use to translate cyclic pumping into a continuous flow. They use the compressibility of air. The same happens in our vascular system. That's a Windkessel. It buffers the cyclic changes and translates that in a continuous flow of water. When the heart, which is also a cyclic pump, pumps stroke volume in the aorta buffers this and then releases it during diastole. So there is a systolic increase, but also a diastolic blood pressure that is maintained, doesn't drop to zero. Now, if arteries stiffen, that distensibility of the artery decreases, and for the same stroke volume, the blood pressure difference between systole and diastole, and that is pulse pressure, increases. In addition, the velocity with which waves travel through the arterial system increases with stiffening too. And actually, a blood pressure signal in a normal human being is a summation of two pressures, the one that is generated by the heart, and at the same time, the pressure that is reflected from the capillaries back to the heart, because pressure travels faster than flow. So if we decompose that, you see there is a forward flow, and there is a pressure traveling back And so the green line here shows systolic pressure and diastolic maintenance improving cardiac perfusion. Now, what if this pressure wave travels back faster? Then it arrives in the aorta while the heart is still ejecting. So it augments systolic pressure and increases the afterload of the heart. The pressure wave is already coming back and we are still ejecting. The other effect is there is no more diastolic, oops, wrong button, sorry, that's bad for the videotaping. So there is no more diastolic augmentation. The diastolic blood pressure is now lower. That means the heart, depending on diastolic blood pressure for perfusion, receives less blood. We see increased pulse pressure for two reasons: stiffening, loss of compliance, and the fast traveling of pressure waves in this system. What does it mean for the heart? There's an increased load to ejection. It has to work during systole while the pressures are increasing, and there's reduced perfusion, making it particularly vulnerable to ischemic risk. And in addition, since there are high systolic pressures, we are afraid that this causes microvascular trauma to the organs, right? But the particular thing in anesthesia is that if we treat systolic hypertension and we bring down diastolic pressures with a drug that doesn't differentiate between systolic and diastolic pressure, then we risk to overtreat and risk to end up in very low perfusion pressure. So the risk of overtreating hypertension is there for systolic hypertension, isolated systolic hypertension. The Framingham study shows that there is an age-dependent increase in blood pressure. But looking at the details, you see that that increase in pressure is primarily systolic pressure on top of this page. Diastolic pressure, instead, is not continuing to increase. In fact, at later age, with stiffening of the vascular system, diastolic pressure even decreases slightly. And so perfusion, pulse pressure, increases in older patients. And this is particularly the population that presents with isolated systolic hypertension. There are indications, particularly in cardiac surgery, that pulse pressure, the difference between systolic and diastolic blood pressure, is an independent indicator, even independent from age. While we know that it increases with age, if you remove age from the equation, pulse pressure itself, and that's hypertensive patients at a younger age with stiff arteries, is an indicator of stroke or a predictor of stroke development. In non-cardiac surgery, we don't have enough evidence for that yet, but in cardiac surgery, there are a few papers that confirm this. So pulse pressure by itself is something we need to look at, as it is an indicator of vascular stiffening. Pulse wave velocity, which requires much more technique to assess this, is also being investigated now as a risk indicator. Now, what do drugs do on pulse pressure? On the right side, you see one graph from atherosclerosis, the journal, that suggests that beta blockers, they bring down systolic and diastolic blood pressure to the same extent, or so not changing pulse pressure, or even increasing pulse pressure, making things worse. That may be an explanation why beta blockers in older patients may cause harm and be the reason why the POISE study, for example, showed cerebrovascular accidents at high dose. Not saying beta blockers are bad, but they don't treat isolated systolic hypertension in a discriminative way. ACE inhibitors, for example, they have a more beneficial effect on pulse pressure, but we have no experience with ACE inhibitors during surgery, of course. We don't have these intravenous access. Now, this for the vascular system and blood pressure. The heart suffers because with time, depending on the severity and the duration of hypertension, it starts to grow muscle. There is left ventricular hypertrophy, which is synonymous for diastolic dysfunction, because diastolic dysfunction is the ability of the heart to accommodate blood in the ventricle at normal filling pressures. Dysfunction means either the heart is not filled well or it needs higher filling pressures to be distended. These are stiff ventricles. This pressure volume loop, for those who are still familiar with the physiology, cardiac physiology lessons, show the pressure volume relation during diastole in a normal ventricle. As you fill the ventricle and diastolic volume goes up, the pressure raises slightly. In a stiff ventricle, that raise in pressure is large. The ventricle does not distend for the same amount of volume. Pressures rise. So in diastolic dysfunction, the challenge is to either not have hypovolemia, because at normal filling pressures, these ventricles are not filled up well, or if you fill too much, pulmonary edema, because pressures are so high that they reflect backward in the lungs and increase fluid loss through the capillaries into the alveoli. So pulmonary edema and hypovolemia have very low limits. Fluid management is quite difficult in such patients. So when we summarize what intraoperative management of hypertensive patients is about, it's about blood pressure control. We know that the autoregulation limits are shifted to the right, so lower pressures are going to induce hypoperfusion, that the arterioles are very hyperreactive. Vasodilators, down goes the pressure. Vasoconstrictors, up goes the pressure because of these small changes in lumen. And so we call that alpine anesthesia, blood pressure up and down. That it is about volume management, because they are very vulnerable to overload and very vulnerable to low cardiac output, and hypovolemia as well. And maybe new monitoring techniques will help us in managing that a bit better. So it's better to measure flow than pressure when it comes to organ perfusion. But how do we measure flow? Near-infrared spectroscopy, for example, gives a better index, a better indication of regional perfusion and oxygenation. So there may be an option to use that more actively. Regarding fluid management, we know that central venous pressures are not very helpful, but there are dynamic loading indicators that may be pulse pressure variation, stroke volume variation, that may be more helpful to titrate volume responsiveness. We are not going into detail in these domains, of course. There are so many other lectures about it. So treatment of blood pressure. Mert, I hope I still have these 2 minutes. Yeah, okay. I'm watching it. What is hypotension, actually? Is it defined well? No. The literature says, I give this reference here, in 2013, there are about 50 definitions of hypotension. So what do we have to consider hypotension? There is an important paper by Terry Monk that says intraoperative hypotension increases 30-day mortality. The definition they use, you can look it up in that article. I took one out, 50% mean arterial pressure down from awake values. For 5 minutes, increases your 30-day mortality. So that's a clear mismanagement if we allow patients to have that. So this is a risk factor. So maybe it's safe to stay away from that damage and consider 30% the maximum deviation of awake values. That's an opinion that has been suggested by not just me, by many anesthesiologists. Like maybe that should be our guide in hypertensive patients, not to deviate more than that. Control awake mean arterial pressure, not systolic pressure. And then there are a few suggestions that we can individualize this a bit more using new monitoring, like Charles Hoke, for example, suggests based on near-infrared spectroscopy to follow the changes in near-infrared and correlate them with blood pressure. If blood pressure decreases, but near-infrared oxygenation or tissue oxygenation stays the same, that's an indication we are still in autoregulation. If blood pressure decreases and NIRS goes down, that means you have reached the left limit of autoregulation. So if there is correlation between pressure and NIRS changes, there is no autoregulation. If they don't correlate, you're in the autoregulation zone. It's a suggestion, and he has actually a few papers now that show that if you use this as your index individualized, for patients, that's the lowest blood pressure where you are still in autoregulation, and stay above that, you save lives. So I'm pretty sure that we are going to see this developed a bit more. It's an ingenious idea. We actually showed that also with spinal perfusion, that after reconstruction of the aorta, blood pressure and NIRS correlate, meaning that the autoregulation is lost, while as before, there was autoregulation. I'm not going to go deeper into detail. Let's go to outcome now. Very few studies that really show an effect of hypertension on outcome. There is indirect evidence, and that's why I bring this slide here, the study by Fayad, who shows that diastolic dysfunction, and I'm not telling you that all hypertensives have diastolic dysfunction, but hypertensives with left ventricular hypertrophy, they have diastolic dysfunction. The diastolic dysfunction in non-cardiac surgery is a risk factor for events. A meta-analysis shows that they are at risk for pulmonary edema, and also 30 days follow-up showed major cardiovascular incidents in patients that had pre-op diastolic dysfunction. So this subgroup of risk patients should deserve our attention for better management. They conclude there is moderate certainty that diastolic dysfunction, preoperative diastolic, perioperative diastolic, I should say, is an independent risk factor for adverse cardiovascular outcome. So I refer again to this article in Current Opinion, where, and this is opinion-based, not evidence-based, there are a few suggestions how to handle these patients in the preoperative phase, intraoperative, and postoperative. I forgot to tell you, but this lecture, I agreed that this will be published on the SMART website, also with the audio recording, so you don't have to take pictures. It will appear there. Thank you very much for your attention.